Our next guest speaker is Gautam Kareti, who will be talking about concussions. Dr. Kareti is a neurologist with a specialty in clinical neurology. He has graduated from the American University of the Caribbean School of Medicine in St. Martin, Netherlands. He completed residency at St. John Hospital Medical Center in Detroit, internal medicine, and at Virginia Commonwealth University Medical Center in Richmond, Virginia, in neurology. He has also completed a fellowship at New York University Medical Center in clinical neurophysiology.
Good afternoon, guys. I was approached by Young Sun Kim, physical therapist, who just showed me how to use this piece. And I have an interest in sports, like a lot of other people, and I found this topic to be very fascinating, and it's something that I've been doing for the last couple of years. So just to continue on with Rick, I was going to get into a little bit more of the detail, like from the standpoint of like a neurologist or a clinician, and how some of the guidelines have sort of come about and what the science is. So essentially, this talk is pretty much to inform really anybody who's going to be involved in seeing these patients, like the most common people, and to try to get to a little bit around the information and the guidelines, how everything sort of evolved. And as well as to highlight people who could potentially be subject to it. A lot of attention has been paid in recent years, and about 5-6 years ago, it was, at that point, it was considered to be a form of traumatic brain injury, and this is because of the untoward effects of a concussion. So it's important that we truly define what exactly a concussion is and who will benefit from this talk as well, and who is at risk. Some of the numbers are pretty staggering, and some of the features and symptoms, as well as a review of some of the slides at the basic level. So this schematic is pretty interesting because it essentially shows a biomechanical force to the head can result in pretty much a functional disturbance. Anytime there's a massive blow to the front of the head, it can be transmitted to the rest of the nervous system, and essentially is what causes this condition. In 1997, we got the first definition of a concussion, which at that time it was thought to be a traumatic-induced alteration in the level of mental status, which may or may not involve loss of consciousness. And that's a key finding right there. At that time, the more information is being gathered, the key thing here is that it's thought to be a traumatic-induced alteration of mental status that may or may not involve loss of consciousness. That's a key point. And when concussion occurs, it's very important to observe the athlete and remove from play for all the reasons that the previous presenter had mentioned. And the key thing here is that head injury is very common in high velocity sports, all the way from soccer. It's very common in young women who are playing soccer because of the headbutting. And the Centers for Disease Prevention found that almost there's only 300,000 cases per year, so that incidence is pretty high. In 2012, 68,000 concussions were found to have occurred in the high school football season. And out of that, 16% returned to play in the same match, and 40% nearly returned to play within the same day. And in 2009, it was found that 35% of these individuals had experienced an earlier head injury as well, and often 71% had occurred during the same year. A large number of these individuals were playing with symptoms suffered previously, and this is really important because anybody who's going to be involved in caring for these patients need to be well versed in the diagnosis and treatment that can predispose to this condition. Because sometimes symptoms may be underreported, it's important for athletes who present with minimal symptoms that all healthcare providers are cognizant of some of these features. And what are some of these features? They may be delayed, they may be slow, that's the key thing. There can be inability to focus, they can be confused. Dizziness, vertigo, oftentimes we as neurologists will see this more 3 to 4 weeks down the road or months away. And one of the other ones was conspicuous incoordination that you can often see while watching TV, whether it's a football match, boxing match, MMA fight. And eventually that can lead to problems with thinking, repeating, and future episodes of possible loss of consciousness. Down the road, later on, patients can develop something called like a post-concussion syndrome, and they can have some later symptoms. And these could be chronic headaches, chronic dizziness. They can also space out, difficulty concentrating, and they may have periods of dizziness as well. And after a diagnosis of concussion is made, it's important to sort of stratify the event, try to get to what degree it was. And there have been several different classification schemes that have been developed and issued over the last several years. Some of the ones from the American Academy of Neurology use experts from Colorado and other faculty members involved in this entity. This is essentially the Glasgow scale, which is important to rate the severity of head injuries on a scale of 0 to 15. What I like to use is a little bit different from some of the way that CIF does it. And sometimes grade 1 concussion, which would be the most common type, patients or the participant would not necessarily be unconscious. Symptoms could last under 15 minutes and very mild in the sense they may see some stars, maybe feel like their bell is rung. The grade 2 concussion would be a little bit more severe. Again, there's no loss of consciousness. Symptoms can sometimes last longer than 15 minutes and may, in some instances, necessitate medical attention. Grade 3 concussion is a little bit more severe, and these symptoms can last for longer than an hour, but sometimes can be very brief. But in this situation, there is loss of consciousness. As a result of this, I just wanted to touch a little bit on the pathophysiology, and essentially, there's a release of glutamate, which is activated, and this results in an increase in energy. So this increase in energy isn't always met by an increase in glucose, and these are just some of the electrolyte changes that we can tend to see. If there isn't an increase in glucose, this can create an energy crisis, and the patients can then be predisposed to further head injuries in the same setting. And this is important to play because if this does create a crisis, there's a lot of post-concussive variability, and returning to play could be very difficult. The massive excitation leads to the neural suppression, which can create a post-traumatic spreading depression. And early on, there can be loss of consciousness and some post-traumatic amnesia with some confusion as well. And it's low. The changes in the brain are low in the first 24 hours due to blood flow and everything else. PET scanning has been found in individuals that were studied that glucose does remain low for about 2 to 4 weeks, but there was no real correlation with the Glasgow Coma scale, which is the how to rate the head injuries, which means that individuals who potentially could be at risk for an event were often normal and were not given sufficient time to heal. Oftentimes these patients may have very, very subtle neurocognitive findings, so it's really important for all clinicians or any individual to be well versed in these symptoms. So when exactly is the most optimal time to return? I think the presentation of the CFF guidelines earlier made a really, really excellent set of parameters to be used. I think it's really important for people to start enforcing these, especially at the high school, college level. It's a little bit different when you get to the professional time because there's so much interest in everything else that is involved. If there is a grade 1 concussion, these people often have to be removed immediately. This has changed in the last couple of years. Athletes are no longer allowed to return to the contest until they've been evaluated by a treating provider. A grade 2 one often requires management to an emergency room or a licensed healthcare provider, and these patients may need to have imaging in the form of a CAT scan or an MRI. And a grade 3 concussion may require longer treatment and a longer period of returning to play. These are some of the Cantu guidelines. He was one of the experts on this, and he had a lot of information to do, and it sort of summarized all those findings that he mentioned. And I just want to highlight this slide right here. 2009, I encountered this. This is a 13-year-old football player who's in Washington State. He suffered a concussion, returned to play in the second half, and he had another concussion, another head injury. And it's this instance, he developed a thing called the second impact syndrome, and this has happened. And basically, because of the really bad functional disorder, there was a lot of swelling in the brain, pressure went up, and essentially had malignant cerebral edema, which is just swelling of the whole brain stem, and you can instantly die. So because of that, that led to a lot of changes over the last 5 years with return to play guidelines. It's also important to baseline athletes and undergo standard neuropsych testings before they were to participate in a season-long event. And baselining helps to compare the current state to the pre-morbid level of functioning. Another slide just highlights some of the salient features of concussions and how important it is to ensure that people are not returned to play at the same time. In the NFL, as Mr. Hogan had presented, a lot of attention in the recent years given to concussions, and a good deal of them will end up having long-lasting changes, possibly even dementia early on. And if you go back and you talk to a high school student, whether it's a college student or pro, a lot of people end up playing sooner, and they return to play sooner when they should have taken a little bit longer. The Sports Legacy Institute was really interesting. Was the ones who eventually ended up finding the features of chronic traumatic encephalopathy, which is just repeated blows to the head, can create a lot of early dementia, early changes. And sometimes in these instances, dementia pugilistica, which is dementia in boxing, they can occur along with, sometimes they're called punch-drunk syndrome, and boxers get this after repeated blow to the head. You can even develop things, behavioral disorders, Parkinson-like features, apathy. In closing, I think it's important to continue to educate everybody, whether it's at the Pop Warner level and on up, develop a concussion management program, carry a whistle, enforce the return to play guidelines. And one time you get a concussion, just like spraining an ankle, it makes the next one all that much easier. Thanks very much.